everybody. We're all welcome to the second in the series of webinars hosted by the African Pharmaceutical Forum, APF, the African Regional Forum of the FIP. We're glad to have you here, and we know that we're going to be having an excellent time together today. We have 25 people in the call, and we're just going to start. So please do us a favor by putting where you're from in the chat box so that we can have an idea of the spread of participants in the webinar. A message to that will be put in the platform also soon. So you're very welcome to this webinar on Never Waste a Crisis, Disruptive Technologies in Africa during and post-COVID-19 pandemic. I'm your moderator for today, Dr. Ariola Joda from the Faculty of Pharmacy, University of Lagos. I'm a fellow of the Pharmaceutical Society of Nigeria and a fellow of the West African Postgraduate College of Pharmacists. And currently I serve as an executive committee member of the academic pharmacy section of FIP, as well as the general secretary for the African Pharmaceutical Forum. We're excited that you are here with us today for this second webinar. And please be aware that this webinar is being recorded and live streamed on YouTube, and the recording will be available on the FIP website, www.events.fip.org, where you'll be able to have access to it soon after the event, so that we can continue to learn from the information that will be shared today. You can put your questions in the chat, in the question box, and please feel free to put your question in the box at any point in time. Our facilitators may respond to you on the chat box, on the question box directly, or they may choose to respond openly so that everybody can benefit better from the questions. But please go ahead and put the questions so that you don't forget it. You're welcome to provide feedback to webinars@fip.org, and peradventure you're not yet a member of FIP, please go to the membership registration tab of FIP to join. So today, as I said, we're here for Never Waste a Crisis, Disruptive Technologies in Africa during and post-COVID-19 pandemic. Indeed, we have come through COVID, but the good things in inverted commas that COVID brought are still with us. And one of it, of course, is the opportunity to have these webinars where we don't have to be face to face, but there are many other issues that we're tackling with because of COVID. So in today's program, we'll do some introduction. We're going to be having 4 different presentations by 4 eminent speakers across the continents. Then we'll have a quick Q&A session, and then closing remarks and closing. Well, you're welcome to join us. So the objectives for this session, at the end of the session, we're expecting that participants will be able to describe the positive disruptions in pharmaceutical supply chain post-COVID-19, understand the need for the uptake of technology for resilience and impact in pharmaceutical services, highlight institutional barriers militating against uptake of digital technologies and strategies to address them, and to describe innovative ways that pharmacists' accessibility can be exploited for the greater good in our communities. The executive committee of the African Pharmaceutical Forum thought it good to begin to host some of these webinars as a forum for us to learn and things that we could put in place in our own environment. Sometimes when we hear things that are happening in the developed world, there may be some constraints because of lack of this or unavailability of that. But when we hear what other people are doing across the continent, we're better able to put those things into practice because we have similar problems going on. So our speaker 1 is Samuel Akufo from Ghana. He is the Africa Fulfillment Operations Lead for ZIP where it provides direction and guidance in operational excellence. Where it provides direction and guidance in operational excellence, stakeholder management, customer experience, and people management as they implement Zipline's global strategy of using aerial logistics to increase access to vital medical products across Africa, especially in areas that are very hard to reach. Due to his dedication to creating healthcare access, he was recently selected as an Atlantic Fellow for Health Equity at George Washington University. He's a pharmacist and a member of the Pharmaceutical Society of Ghana. Please join me as I welcome Pharmacist Samuel Akufo for his presentation. Over to you, sir.
All right. Good afternoon, good morning, wherever you are. It's afternoon in Ghana. Thank you for having me here. So today we're going to go through supply chains and how it was disrupted during the COVID-19 pandemic and post the pandemic. We'll go through some of the quick facts about the pandemic. I'll talk through how COVID-19 generally affected pharmaceutical supply chains. I'll also throw some light around how to we understanding supply chain planning and execution, how traditional supply chains are supposed to be were working before COVID, the opportunity for disruptive technologies, and how COVID was managed in Ghana using a complementary aerial logistics and ground system. And also we'll try and go through what post-pandemic it looks like in Ghana. Next slide. Next slide, please.
I've changed to the next slide. Can't you see it?
No, please. Yes, this is the slide. Okay. So COVID-19 took all of us by surprise. It was a time when there was a lot of uncertainty. We didn't know what was going to happen at any point in time. It was interesting, but we were all sort of stuck in our homes because there were a lot of lockdowns that were put in place to prevent people from moving from one side to the other because of course, people contracting the virus. Healthcare systems generally faced a burden, and in Ghana in particular, though we are a low middle income country, and we are doing really great growing our economy, it was tough because it puts an economic strain on everybody. Now the government has to provide a lot of incentives here and there to be able to keep the economy going. Global economies generally were having deficits, and it wasn't just a Ghana thing, it was a global thing that was happening. And because of the spread, that the mode of spread of the virus, movement of people and goods were generally restricted. And so you were at home, and even if you needed something, you couldn't go out only when you only could go out when you needed something essential like food or something. And so generally, people and movement of people and movement of goods was restricted. People started implementing the use of Zoom a lot in their workplaces, where you'd rather have meetings on Zoom rather than go to the office because we are trying to avoid all that. Now, to try and understand how supply chains work generally, we need to really have a clear picture of how it works and how it was working generally before COVID came into the picture with its surprise. Generally, there's demand planning. Demand planning basically means that there's a forecast of what is going to happen at the downstream. By downstream, we mean the patients, the customers who eventually consume our products. There has to be planning of what is going to happen, and it usually comes from the downstream in terms of the quantities that are being used at the downstream. There's also supply planning, and so manufacturers, distributors all have to plan ahead of time. They have to put in place a plan for how they're going to get their raw materials to do manufacturing. They have to put in place plans of how they're going to supply their customers all across different geographies. And so the demand really linked to the downstream. And so having that understanding gives us a clear picture of what really is going on. Capacity planning. Capacity planning is basically when you have these manufacturing setups, manufacturing products from one point to the other. They need to take into consideration generally how much I need to manufacture at every point in time. And so capacity is basically how much can I manufacture at a go. what do I need to manufacture at a go? And all these are some of the considerations that are made. Production planning has to do with generally scheduling. How do I plan in manufacturing plants that produce pharmaceuticals that multiple pharmaceuticals in the same plant? They have to do what you call scheduling to know when I provide for this product and when I manufacture this product, when do I use the plant for this product and that product, when do I switch over? And so production planning is also some of the key things that are considered during supply planning, inventory management, as well as sales and operations management, operations planning. Whatever you're producing or whatever you're distributing, it has to be in line with what the sales feedback is telling you. So the sales team is out there promoting the product, pushing the product, customers are receiving the product. There has to be that sync. So generally, these are the key things that are considered when we are planning the supply. Next slide, please.
I'll move to the next slide.
Okay. Other things that are also considered during supply execution is taking orders. So order taking, scheduling of orders, picking and packing of orders. So for those in the logistics industry, picking and packing, scheduling, all those things go into being able to fulfill an order that would come to you from a distributor or from a supplier, managing customer feedback, shipment of consignments, and receiving of goods. So you can see that in totality, the supply chain is a very well-planned system, right from demand planning, capacity planning, production planning, all the way through the logistics side of things. And so it is all planned through. And so what this means is that whenever there's something that is uncertain that affects the supply chain, then it's going to lead to a disruption. Next slide, please. Now, in terms of how the supply chain was affected, if you're looking at the upstream and downstream, upstream is basically from the supplier end, and the downstream is basically at the customer end. There's supply chain basically is about the flow of goods and the flow of information. You could see clearly that based on what I mentioned earlier on, when the lockdowns were instituted, restriction was imposed. And so there's flow of goods is restricted. But one thing that flows is information. The same way we are here having a conversation through Zoom is we are sharing information. I'm sharing information with you. You are sharing information with me. So flow of information was possible. But what could not happen is movement and flow of goods. And it was noticed around the world that supply chain executives basically were a bit distraught by the uncertainty that it posed. There was a textbook risk that they were immediately imposed on. Due to the lockdowns, flow of products became a problem. Availability of even public transportation posed challenges to people who had to go to their scheduled appointments. So if I had a doctor that appointment that I had to go see, that would be a problem. If I had to move from one point to the other to go pick up medications, that would be a problem. Looking at the origin of COVID-19, COVID-19 originated generally from, as we all know, from China. And China is a huge contributor to the global economy, being responsible for about 12% of the total exports in the world. And when that happens, it means they have a huge stake when it comes to the distribution and supply of all kinds of materials, including medications, raw materials, APIs, face masks, and all those things. So an immediate lockdown, when immediately there are lockdowns, what happens is that there's an immediate loss of access to these vital goods. And that took a toll on the world, because once they impose lockdowns and there are restrictions, it means that raw materials that manufacturers would need, APIs, would not come in place, will not be available for them to be able to manufacture. And so manufacturing industries would struggle. Next slide. Distributors would also have a big problem, because then if manufacturers are not manufacturing on time, the products are not getting to them on time, they are also unable to distribute. And so they are also left in a situation where they don't have enough stocks to distribute. They are also concerned because there are risks with expiries, because at the downstream as well, customers are not consuming the product. And if there's no consumption happening even at the retail level or at the customers directly, then the stocks are going to stay with these distributors. And what that means is that there's an increased risk of expiries. There's also increased import lead times. And so for those who are not maybe in the manufacturing, but are involved in distribution based off importation, the lead times disrupts everything because you are expecting things to come in within a 3-month period, and then it ends up happening over a 6-month period, and that just puts a strain on everything. Globally, the low and middle income countries are the ones that were hit the most. And looking at the economics of things, it was said that $52 billion is what would cost these low and middle income countries to provide effective healthcare response for 4 weeks. And putting all the low and middle income countries together, that's a huge deficit that they would go through. That some of us are still, some countries are still, as at now, going through an economic downturn. Research has also proven that the people that were affected the most are the people who are really in the hinterlands, the hard to reach communities, the underserved communities who are exposed to extreme poverty, because they are in the hinterlands, difficult to reach communities, difficult access roads, mountainous areas. These people were hit a lot because supply chain was not serving their benefits. Next slide, please.
I've changed the slide since. I don't know why you're not seeing it.
I'm only seeing the previous slide.
Let me go back to the previous one. And then can you see the new one now?
No, please.
Oh.
Yeah, I can see the yeah. Next slide, and then the next.
Are you on the next slide now?
Yes, so the next one after this slide.
After this.
Yes, please. Yes. So in terms of all that I've said, the key thing that this puts to mind is that supply chains generally need to be resilient. And resilience is like the big word that we need to all have in mind leaving this presentation. The resilience that we are talking about has to do with a number of things. And now, how do supply chains become resilient? Previous slide, please. The slide on resilience.
Can you see it?
Yes.
Oh.
So the slide on resilience, yes, I have that slide now. In terms of adaptability in the supply chain, adaptability is the first thing that you want to consider when you're talking about resilience. By adaptability, what I mean is there has to be that level of flexibility. So COVID has taught us one thing, that for us to be able to have supply chain systems that are resilient, we need to be able to have that flexibility built into the supply model. Whenever you're designing your supply chain, there are different stages. There's a supply chain design stage, there's supply chain planning, there's supply chain execution. In the design stage, one of the key things that need to be considered is, how do I make this thing flexible? There are certain products that have an agile supply chain where what it means basically is that they only produce based off an order. There are certain supply chains that have a traditional push model. There are some that run based on a pull model. What this means is that if you are designing your supply chain, what COVID has taught us is that you need to consider flexibility and have backup plans. You need to have effective use of data, because if you have enough data to be able to, from the downstream, to be able to tell you what your demand is, you're able to forecast better so that you don't just run your supply chain based off intuition, but based off data. A risk-based supply chain design is basically building risk into the supply chain such that during the design, you have considered all the failure modes. By failure modes, I mean what could go wrong. And so in designing the supply chain, you want to consider what could go wrong at any point in time. And these are some of the things that had not been considered on a large scale before COVID. You also want to increase the partnerships and collaboration. Supply chain is such that it's one person alone cannot form a supply chain. It's a collaboration of multiple parties that form a network. And so to be able to be very effective, you need to be sure you have very great relationships that you can fall on when things are not going as expected. Next slide. Now, what was done with respect to ground logistics during the pandemic period? So during pre-COVID time, the traditional supply system played a very huge role in Ghana. Pre-COVID, they were involved in the distribution of essential medicines, and this was a bi-monthly work stream that was done with the Ministry of Health to be able to deliver the framework instituted products from the central medical stores. And they got a lot of support from donors, and there was also last mile distribution, usually within the regional medical stores, to be able to deliver to the last mile, which is like the facilities that are in the hardest to reach areas, CHIPS compounds, hospitals, and the health posts. And that was something that was happening during pre-COVID. Now, during the pandemic era, due to adaptability, as I mentioned earlier on, and being flexible, the ground logistic providers adapted to different capabilities. They, instead of doing the traditional thing, they improved their system to be able to distribute COVID-19 supplies such as PPEs, test kits, medical devices. We even had Imperial Health Sciences partnering with the Ministry of Health and the Ghana Armed Forces to do the distribution of beds, mattresses, and also helping the setup of COVID-19 response centers, distribution of oxygen, and all those other things that ground logistics would be a great tool to use. We also had support from DHL, UPS, who supported in the distribution of bulk COVID-19 vaccines. And so you can see here that ground logistics, which already existed as a key partner to the Ministry of Health, evolved on its own to be able to fit in there. Now, the opportunity that this COVID-19 pandemic brought into disruptive technologies generally, as I mentioned earlier on, the flow of goods was restricted, but what was not restricted was the flow of information. And it's a fact that people spent more time on social media. I remember TikTok as an app was one of the apps that blew during the COVID-19 era because people were not going anywhere. They were spending a lot of time on TikTok. The opportunity was huge within the tech space for any technology that could pass information without necessarily moving physical goods, because you can move information. All you need is internet, and the availability of internet also brought up a lot of these technology-based technologies like telemedicine, doing consultations on the phone with your doctors, and a whole lot of other internet-based technology. What this also did during the period was that all apps that had marketplaces or apps that allowed you to buy stuff online also increased their activity, because all you needed was internet to be able to distribute or to be able to sell whatever it is that you wanted to sell. Pharmacies also adapted to their model to move towards more of home delivery, and so you can order your over-the-counter medication, or if you have a refill that you have to do, they have the supply to be able to they have a motorbike that can be able to deliver to you wherever you are. Now, how did Ghana manage the pandemic when the supply chain was disrupted? So during the pandemic in March, there was a lockdown that was imposed. There was a lot of preventative measures that were put in place, like distribution of PPEs, hand washing, and all those things. The issues that came up were that ground logistics to hard to reach areas became very limited. There are facilities in Ghana that are on islands. There are mountainous areas. There are areas where the ground logistics just cannot get to. And based on what I mentioned earlier on about these are the communities that also faced a lot of issues, it became a problem. So what the government of Ghana did was that it commenced a collaboration with other options that it had. And so there was a collaboration with the use of aerial logistics, which most people know as drones, with Zipline. And during that period, you could see clearly on our right side that when the lockdown was imposed, there was a huge demand for distribution of vaccines in Ghana by Zipline, because these orders were coming from communities that were in some of the hardest to reach areas, and the ground logistics could not get to. So that lock and key collaboration between the ground logistics and the aerial logistics was something that was able to bridge the gap during the the disrupted supply chain period during COVID-19 pandemic. Next slide. So
I've moved to
also, also during the COVID-19 pandemic, another key thing that was happening was that the government of Ghana was instituting a lot of testing so that we can be able to identify and treat and manage a lot of people. There was a huge backlog of samples, test samples, I mean, and so there was a collaboration with the aerial logistics partner Zipline to be able to distribute or move test samples from the inner communities or the inner towns and the rural areas to testing centers. And this was the first time anywhere in the world that an aerial logistics was being used to do something like this, make a delivery um, into an urban area, delivery of test samples. And this was something that was able to support the ground logistics in a way that was unique, because ground logistics would then focus on some of the areas that are easy to get to, while aerial logistics will do distribution to for the hard to reach areas, so that testing can happen and then we can be able to manage a lot more people quicker. Next slide. Eventually, the COVID-19 vaccine was ready, and Ghana was one of the first countries to receive the stocks. And this is why Ghana had at that point in time, had a very resilient supply chain in terms of what's the setup that we had. So Ghana had last mile distribution by ground, and Ghana had also aerial logistics. So the plan generally when the COVID-19 vaccines came into Ghana was that the EPI, which is the expanded program on immunization, was going to deploy to reach 20 million people in phases, starting with the highest risk groups. And the distribution was going to advance into very rural areas. And based off the EPI's gap analysis, cold chain storage was where issues in some hard to reach communities, some hard to reach communities were just not accessible. They were on mountains. Some of them were behind rivers and very hard to reach areas. So there had to be a lock and key collaboration again with aerial logistics to be able to move these COVID-19 vaccines from the cities into the inner areas, the rural communities. Now, the vials of vaccines were received, I think in 2021, about 1,329 vials, and then till date, about 3.3 million doses of COVID-19 vaccines have been delivered across Ghana. And this is because of the complementary lock and key system that I mentioned, where during a disruptive situation, you have two systems that allow you to be able to stay very adaptive. And so we have ground, we also had air. The areas that we were unable to get to by ground, we use air to get there. Next slide. Now, post the pandemic, what we've realized has been that there has been an integration of like COVID-19 supplies into the MOH's bi-monthly schedule. And so that has been like something that has been instituted to ensure that even after the pandemic, we are distributing COVID-19 vaccines to the communities and to the areas that have not yet received it by using a bi-monthly MOH schedule, which is currently ongoing. There's also consolidation of multiple health commodities for distribution of improved cost efficiencies. So instead of distributing, so we've just remodeled our distribution in Ghana to ensure that we are consolidating multiple health commodities that we can send together and at a go to improve the distribution and also reduce the costs that are incurred. So generally, if you're going to be distributing maybe TB, you're going to distribute malaria or something, these two different commodities at different times, we have found better ways of being more efficient at distributing them together and consolidating that. There's been integration of both ground and aerial logistics during vaccination campaigns. So during vaccination campaigns, if you look at some of the hard to reach areas that we have to serve, those hard to reach areas are handled by air, while the ground distribution supports the areas that are within the cities and the easier to access areas. There's been the dedication of hard to reach facilities to be served solely by aerial logistics. There's also been centralization of certain products. There are certain products that have an erratic supply chain, and it just makes sense to that's like because of their erratic supply, you cannot really tell when you're going to run out of stocks or not. And so combining aerial logistics and ground logistics allows you to be able to bridge that gap. The government of Ghana has, I'll say, has also been very open-minded about new technologies, not just aerial logistics. There are a lot of other technologies that are coming up in Ghana, and the collaboration is in the next few years is going to prove to be very beneficial in a way that is going to revolutionize healthcare. Telemedicine, I know, is something that is ongoing. There's a lot more that's also coming up. In conclusion, I'd say that when it comes to disruptive technologies, we cannot run away from them. In the next few years, with the advent of AI, there's going to be a lot more of these technologies, robots, and things that would get into the healthcare industry. And so we need to understand how we can use them to build resilient and robust supply chains that would be very responsive during a crisis period. Also, we need to get to the point where healthcare systems and managers are open-minded about integrating these technologies, because some of the issues that we had integrating this technology within our supply chain was initial resistance because it's a novel technology and people do not really understand how it works. But being open-minded and also, of course, working with policymakers, we can be able to arrive at a middle ground where we are doing things within policy while we are also being able to deliver excellent service to our patients who are out there. Governments must encourage more private-public partnership. This aerial logistics partner is a private partner. But I'm aware that there are a lot of homegrown Ghanaian and African technology companies that are coming up, and it's ideal that government encourages more of that public-private partnership, so that we can be able to build the next generation of technology tech enthusiasts who will be able to improve our healthcare. Now, finally, training of the next generation of healthcare professionals needs to really include some exposure around disruptive technologies. As I said earlier on, it's not going anywhere. And so as we are training pharmacists, as we are engaging students and all that, they need to understand that that is an opening, that's an opportunity for innovation. And so that is something that they can take advantage of coming up in the next few years. Thank you so much for the time. I appreciate it.
Thank you so very much, Fam Akufo, for this presentation. And I know that quite a bit of information has come forth, which various other countries can see how they can key into this aerial logistics availability for their own countries. So thank you so very much. As I said, there will be time for question and answer after. So anybody that has questions for him should put it in the chat box, or we can discuss it at the end if we have time. So our speaker two is from Adesina Panubi from Nigeria, talking about technology as a tool for resilience and impact in times of uncertainty. Pharma Panubi is the lead consultant of Shine and Cloak Consulting and the project catalyst for Pharma Alliance, Africa's first retail pharmacy business support network, a group with a retail footprint of over 200 retail pharmacy stores and a combined annual turnover of over 52 billion naira. He has over 20 years post-graduation experience and rose through the ranks as a pharmacist to become the customer relations manager of Pfizer Specialties Limited, with responsibilities for Nigeria, Ghana, and the entire East Africa region. He's a recipient of the prestigious Pfizer Global Innovation Award, which was presented in New York in 2011. He voluntarily retired from paid employment in 2013. Additionally, is a thoroughbred business development coach, and he is the convener of Nigeria's premier annual retail pharmacy business summit, tagged the panel, the largest convergence of retail pharmacy business leaders in Nigeria, with the 15th edition hosted earlier this year. Please join me as I welcome Shino to present his for his presentation.
Thank you very much, Professor Joda. It's a pleasure being here to share my thoughts with us all. So the next 15 minutes, I'll be sharing my thoughts around technology being used as a tool in times of uncertainty and building resilience, something similar to what we saw during the COVID era. So by way of introduction, the like we all know, the global pandemic, when it hit us unannounced in the year 2020, had a profound challenge, for most industries worldwide. And with the pharmaceutical sector being at the forefront of this battle, essentially because it was a health challenge and the solution was going to come from us. However, you'll agree with me that in the midst of this crisis, that enveloped the world actively for about a year, a number of opportunities for innovation and positive transformation emerged. And those are some of the things we'll be looking at this time, and focusing on the key learnings as we proceed. Now, if we were to take a shot at how to describe the African healthcare space, how would we describe it? Using words like being comatose, poorly funded, poor infrastructure, grossly undermanned. In Nigeria, we call it what we call mass exodus. Is the Japa syndrome. I was speaking to one of my friends, and he was like, "It's a global challenge. People are moving from areas of what is termed lower opportunities to high opportunities." And sometimes you look at these things and you run it through the lenses of basic economics, and it doesn't make sense, essentially because you would expect that when supply drops and the demand is intensive, prices will go up. But then I ask healthcare professionals whether their prices, meaning their salaries, have gone up, and it doesn't seem so. And in the midst of all this, we have inter and intra-professional rivalry. It was even reputed at the time during the COVID that based on the strength and the resilience of the African healthcare system, someone said that we were expecting to be picking dead bodies off the streets of Africa. Well, we thank God that did not happen. So I'd like to use the SWAN as a typology in analyzing my message for today. And it is, so if you were to picture what a swan is in your mind, based on what you were taught in primary and probably secondary school, you'd have said, okay, one is a white bird that floats on water and then on land and all that. Yeah, so that was conventional wisdom until one day it was found somewhere that there was a black swan, and that raised some measure of curiosity. And that led to, so I'm calling the COVID-19 pandemic as a classic black swan event. There's actually a book called The Black Swan, written by Nassim Nicholas Taleb. And so if we say a black swan event, what will a black swan event be? It's an event that is unpredictable, beyond what is normally expected, and has potentially severe consequences. And I'm sure you'll agree with me that COVID ticks all these boxes. Now, there are 3 attributes for an event to be called a black swan event. Number one, it must be extremely rare. So when we were told that, the whole world will be locked down, they won't be able to move anywhere, I mean, that was something we couldn't even imagine. For an event to be a black swan event, the impact must be severe. You will agree with me that the impact of the COVID pandemic was severe. And thirdly, for it to be a black swan event, retrospective predictability must be there. What does that mean? When you think back, you should be able to say, really and truly, there's no reason why it did not happen. So right now after COVID, if we look back, yeah, it wasn't a miracle. It was something that was bound to happen. We just didn't expect it to happen. And of course, during COVID, we had images very similar to this. We learned a number of new things, how to use masks. People were wrapping themselves in all sorts of things, just to avoid getting the virus. And so all over the world, in most parts of the world, there was a lockdown. We were forced to wear masks. Even though we'd been taught to wash our hands since we were children, we learned to do it diligently. We couldn't go to school. We couldn't go to work. For those of us in this part of the world that love to party, we couldn't party, social distancing, we couldn't hug, we couldn't shake hands, We now have to learn things like remote work. We have to learn remote worship, remote parties. People are now having weddings on Zoom, and all those things. But the interesting thing is that we were told that the world will never go back to its old form. But if you ask me, I think we're back to where we were before COVID. So I put this picture here, like it was said, I host a national retail conference. It's tagged the panel. And this picture we have here, the 11th edition, which was the year before the COVID. Our theme for that conference was Disrupt or Be Disrupted. And the man here is Leostan Eke, one of the technology magnates in Nigeria. And he made a very profound statement. He said he was talking to his Reverend Father friend. And he told his Reverend Father friend, remember this was 2019. I said to the Reverend Father friend that, look, the church should go online. It's more convenient and all that. And he was winning the argument until the Reverend Father asked him, how will we administer Holy Communion online? And he said, he stood, man, when we get to that bridge, we will cross it. Dear colleagues, less than 1 year later, we were at the bridge. And I'd say that one of the organizations that adapted fastest to COVID were most of the new generation churches, because they used to stream their services before. And so it was a quick shift. Most people had to learn the ropes in the midst of COVID. And so what I say here is that those that benefited the most from the crisis were those who were prepared earlier. The next crisis, the people who are going to benefit from it are those who start preparation today. And so who are the winners of COVID? I'm going to share 2 examples. The first speaker made allusion to some of them. Number one of them was Zoom, which is the platform we're on now. There was Zoom before COVID, right? But at the advent of COVID, between 2019 December and April 2020, their subscriber base jumped by 30 times, from 10 million to 300 million subscribers in a space of 4 months. That is what happened. Of course, they didn't plan for COVID, but they were ready with the technology. What else? Because we were all now nesting at home. This first speaker spoke about TikTok and the rest of them. Netflix, they grew their subscriber base in Q1 of 2020 by 15.77 million subscribers. And so that goes to tell us that if you are positioned and ready, when the opportunity comes, you're gonna have a ride. That's why it is said that the man who is lucky is the one, or the one who is said to be lucky is one who was prepared when the opportunity came. My dear colleagues, how are we preparing for the next crisis, which is surely going to come, but we don't know when? Now, Peter Diamandis, there's a book he wrote, The 6 Ds of Exponential Growth. And I'm going to dwell a bit on it when I get into, there's a slide I have on Zipline. Interestingly, the first speaker is from Zipline. And for any technology to have exponential growth, it must go through these 6 steps. The first is to digitize it, digitize the solution. It then moves into a deceptive phase where people are asking themselves, is this thing possible? Can it work? It's just a hobby. Then it disrupts the market. Then it gets to the demonetized level, dematerialized and democratized, where everybody begins to use it. And so, dear colleagues, as we move into the next slide, I'm here to tell you that we still have more black swans coming. Things that are going to come that are going to have great impact, retrospective predictability, and have a severe impact on what we do. Just begin to ask yourself, is there a possibility of an earthquake, a volcanic eruption, a tornado? Those are things that can happen. But then they may happen with the global warming right now. They may happen in places where they never happened before. So in Nigeria, we're not used to earthquakes and tornadoes and all those things, but guess what? What if it happens? Now wars are beginning to come more rampantly on the African continent and even globally. While we were busy grappling with Ukraine and Russia, now we have Hamas, Palestine and Israel on the world. Who is next? And so the more we are able to prepare ahead of these things, the better for all of us. So where are the opportunities? And I want to say this, that as we begin to move in, because I'm going to round up now with the opportunities, we need to begin to leverage the power of why not. Most times we have what we call conventional wisdom. This is the way it has been done. The days of my forefathers up till now, as it was in the beginning, so it is, and the world to come. Amen. You know what I mean if you belong to that sect. Now, so why not? The pandemic underscored the importance of embracing digital technologies in the pharma industry. From telemedicine to e-prescriptions, digital transformation has become a necessity. And it has forced us to move into previously uncharted territories. And we found that there were some things we thought were far-fetched that were actually well within reach. My dear colleagues across the world, because I see that we have a whole lot of people from India, Indonesia, and all over the world, it speaks to all of us. Now that the pandemic is over, can we go back to some of those developments and use them as the foundation blocks upon which we build a more resilient and adaptive healthcare system? The African pharmaceutical companies must leverage this momentum to enhance their operational efficiency, improve supply chain visibility, and of course, offer remote healthcare services. And so, like I said, we have more black swans ahead. The question is, are we ready? What we need to do is what we call scenario planning. Let's begin to ask ourselves, what if this happens? What if this happens? What will be our responses to these things? So let me start with learning and development. Don't worry about that guy. He most likely is doing a pharmacy course, probably taught by my lecturer 20-something years ago, Professor Joda. Maybe I look like that in the exam hall. I would not know. She can tell me better. But I asked myself, can we rethink the B.Pharm or PharmD degree? Is it possible for it to be an online degree? I checked the attendees and I know that a number of lecturers are online and they may come for my neck now, but let's just hold on a bit. The question is, why not? Why can't the B.Pharm degree go online? And just like Leo Stan AK asked us in 2019, I've been asking myself, and the more you ask why not, the more the solutions come. Can we do the theory online and then can we have custom-built practical labs where students can go book sessions, go and do their PCT, cognosy, and all the rest? Who says, do we know what will happen that will necessitate the implementation of these things I'm throwing out? Let's give it that's food for thought for us. What of continuous professional development? Now we have finished our primary degrees, but we must, like the 7-star pharmacist, the pharmacist is the continual learner. How are we leveraging this? Where is the content? Is it relevant? Is it impactful? Is it useful? Is it practice specific? As a community pharmacist, do I have a place where I can go and learn community pharmacy, irrespective of where I practice? And I'm going to share a case study with us. About 10 years ago, or maybe let me just, to be safe, about 12, 13 years ago, the Pharmacy Council of Nigeria has a mandatory continuing education program. So all pharmacists must compulsorily improve themselves in every 5-year cycle by taking 3 modules. And the way it was done then was to look for the closest pharmacy school to you. Sometimes it was 3 hours away, sometimes it was 5 hours away, but you had to do it. And then technology came in and a portal was built where within the comfort of your home, in your bedroom, you could take these courses, get assessed, and you get your points recognized by the council. Today, there's an improvement on that. There's outside the pharmacy sector, there's something called U-Lesson for primary to secondary school students, where they have lessons online. There are live classes. There are, and I know that it's across the African continent. You could, check it out in your spare time. There's also a portal going to be launched next year, January, Pharm Academy, and this is targeted at the African pharmacy space, where every sector of pharmacy is going to have the customized content built for them just for their learning, everything online. So somebody in Zimbabwe, Zambia, Ghana can come online, teach, and also be taught. So this is the PCNMCPD portal where pharmacists now go to get their practice-specific content, relevant to the work they do. So as a hospital pharmacist, you have hospital content, regulatory pharmacy, you have regulatory content and all that. And this is the other portal I told you about, pharmacademy.com.ng. It's already live in a beta testing state right now. The courses are loaded. The conference I told you about, all the 15 years on the platform, the lecturers are there. And even there are collaborations with the existing faculties of pharmacy to bring some content on the platform. The next thing we're talking about now is patient consultation and engagement. And this is where telepharmacy comes in and telehealth. Let me call it telehealth because there's telemedicine and telepharmacy. And it was actively used by the Lagos state government for managing patients who did not have serious cases during COVID. And these are things we can also do. We can also have healthcare promotions using social media. And I believe strongly that for conditions like dermatology, medication reviews, nutrition guidance, these are things that can very well, I'll call them low-hanging fruit when it comes to telemedicine. My time is fast spent. Let me just quickly rush. Imagine this scenario where we have here, you are in your home with your wearables, and then you have your SpO2 device measuring your oxygen, is connected to your phone, is going into the cloud, your doctor is reading it. That is the future of medicine. Are we ready? Let's not wait for the next pandemic or the next disruption to begin to put these things in place. Let's begin to actively do them. E-commerce, of course, there are pharmacies that are online. We used to think that these things were difficult, but COVID taught us that, look, we could buy anything online as long as the logistics was good, and so that's one of the benefits of COVID. Supply chain, this is where Zipline comes in. Now, they have a very interesting technology. A number of people still think, will this thing work? How much can it carry? And that's why I say using the 6D framework, it's right now in the deceptive phase. People are not sure, is this a fad? But believe me, once with the improvement of technology and the more it can carry, as of today, I know it's actively used in a place like Cross River State in Nigeria. And that place is a place in mountainous regions and others. And these drones are being used to deliver to the health centers already in Nigeria. For emergencies like blood donations and all that, these UAVs can be used to deliver those things, vaccines and the rest of them. We need to begin to think very actively about this. Visibility, are we able to put these things in a supply chain system? And then as a receiver, I know it's at this point, and I know when I may get it. It's working with DHL, it's working with UPS. Why can't we bring it into pharmacy? And in pharmacy administration, as I begin to round up, geospatial mapping is very important because the more we have geocoded locations, then it's easy for us to even leverage existing technology, payment processing, and then, of course, meetings and conferences. This is a geospatial map of community pharmacies in Nigeria. And so it already, if you look at this map, layered with population data, it tells us where the opportunities are and then how the pharmacies are populated. Let me go a step further and then look at a particular state in Nigeria, that's Oyo State. You will see, for instance, that even though you have a number of places, these green places, which means they are heavily populated, the pharmacies are centered in one area, and that's the Ibadan area of Oyo State. It means that even though there are opportunities in all these other places, we only have a few pharmacies scattered there. With technology, we can begin to look at where the opportunities are. How do we serve these places? How do we use technology, either through telemedicine or using technology like Zipline, to reach these far or hard to reach places or these underserved areas? I mean, this is a payment solution that is currently in use in Nigeria, where all payments to be made, irrespective of the number, is just done with a click of a button, and all the associations get their money online real time. This is the conference that was spoken about, the panel conference. This is what a typical conference looks like. But guess what? During COVID, this was the conference where we had to structure, we called it a studio conference, and we were streaming the conference online. The COVID pandemic made us take the conference online. It was initially a 2-day conference, but because of the demand we had to make it a 3-day online conference. But guess what? After COVID, the conference then evolved into a hybrid conference, such that every year we have an online conference equal to the number of people who are physically on ground. That's the power of technology. As I said, what's the way forward? We have learned a lot of things during COVID. Let's not pack them aside, waiting for the next pandemic to come. Let us build them, use them as foundation blocks, and upon them, build the future of our profession. So we need to break the walls. Let there be no divide between Ghana, Togo, Kenya, Malawi, Zimbabwe. Let's have one Africa. Let's begin to learn from each other. What is working in your country that I can bring into my country? Now we know of the AFCTA. Now we know of the PAPS payment system. How are we leveraging this to grow our industry on the continent? We need to build partnerships. In Nigeria, one of the delicacies we have is beans and bread, because they are going beans. Now, if this woman selling bread goes on her own, the woman selling beans goes on her own, they would sell, but the convergence help them potentiate their activities. So they need to work together. Dear colleagues, how are we working together? How are we leveraging technology? Maybe you are the bread, technology is the beans. How do you work together to drive value? We need to feed up the energies of ourselves. All the phones on this screen are being fed by this generator. So imagine the portal I told you about where there's e-learning. At that point, that is the repository feeding the rest of the continent. And these are the things we need to begin to think about as a continent. That is the only way we can be resilient. And that's one of the ways we can continue to build impact for the world we are going into. And innovation comes in steps. You don't need to get there fully at once. Some people call it fake it till you make it, but I mean, this is still a flat screen, however you want to look at it. So let's continue to take our incremental steps of improvement until we get to where we are. We may not start from where Europe or America is, but as a continent, we need to continue to build on what we have till we get to where we're going to. There's uncertainty ahead, that we know for sure. However, when the going gets tough, like we always like to say, only the tough get going. How tough are we as a people? And dear colleagues, we all know this. Tough times never last, but only the tough people do. Thank you very much for having me. I'll be available for questions when it's time. Thank you. Over to you, my lecturer of over 23 years, Professor Jordan.
Thank you, Shin.
I was not sure whether this was
well.
an examination or something, so, you know.
You did well. I will score your script. Don't worry. I'll score it appropriately.
All right, well.
Thank you very much for the presentation. And I'm sure there is a lot of take-homes that we have from what he has shared, from the black swans to the geo mapping to enable us to see where opportunities are. So thank you very much for your contributions to this webinar. So our third speaker is from Zimbabwe, and she'll be talking to us about, sorry, just 1 minute. She'll be talking to us about addressing institutional barriers to digital technology adoption. To go through her biography, please just give me 1 second, 1 second, please. So to read Dr. Murray's biography, Dr. Murray is a Zimbabwean pharmacist, innovator, and global health researcher. She has received awards and recognition for academic excellence, leadership, digital innovation, and entrepreneurship in Zimbabwe and abroad. She holds advanced degrees in public policy and global health from the University of Edinburgh. Her doctorate focused generally on the use of digital tools for the delivery of health services, e-health. Dr. Murray is the founder of the Medical Information Service, from which she has been able to identify gaps in getting information across in Zimbabwe. So please join me as we welcome Dr. Dudze Murray for her presentation. You're welcome.
Hi, everyone. I don't know if you can hear me.
Yes, we can hear you, ma'am.
Excellent. I've switched on my video, but I'm going to switch it off because if you can see me, you can see I'm in a vehicle, and if it starts to move, it won't be very nice to look at. So I've just switched on my video so you can see me, but I'm about to switch it off now. I hope you guys don't mind. Excellent.
No, we don't mind. Thank you so much.
Excellent. So this brief presentation is just going to cover what we mean by institutional barriers and why they are a problem, why they are stubborn, and why they are resistant to change, and how they hinder technological advancement or adoption of digital technologies. We are all here talking about the benefits of adopting digital technologies in the pharmaceutical sector. So we need to identify the things that hinder the efficient adoption of such technologies, which are obviously beneficial. We need to find out how to identify these institutional barriers, because we then can overcome them if we can identify them. So briefly, that is going to be the essence of my presentation, and then I will take questions later, either in the chat or in the Q&A section. Next slide, please. Right. So when we are defining institutions in the context of this presentation, if you look up the definition of institution, there are two types of definition. So one meaning of institutions refers to organizations, like it's a health institution or an educational institution, stuff like that. But that's not the definition we're looking at in the context of this presentation. In the context of this presentation, when we say institutions, we're talking about beliefs, practices, ways of seeing, ways of doing things, our cultural practices, things that are so embedded within us, that are so taken for granted, that we might not even identify them as institutions. They're things that are deeply held, and almost make up the fabric of our society, of our living. These are rules, these are regulations. These things are things that have consequences if you violate them. And healthcare is particularly full of institutions, because it's a sector that has so many rules, because they're necessary. Rules and regulations in healthcare are very necessary, because when we don't adhere to rules and regulations, bad things happen, people die. So healthcare, by its nature, by design, has a lot of institutions, a lot of rules, which is great, but it can be a problem when you want to change things in healthcare. So maybe next slide now. So when we're talking about institutional barriers, we're talking about barriers that are linked to institutions, or barriers that are institutions themselves, barriers linked to beliefs and rules and normal ways of doing things and the like. So why are we looking at them? Why are we interested in institutional barriers or institutions? Because they are stubborn. They resist change. In order to improve healthcare sectors, we need to embrace some form of change. But that it's a tug of war, it's a paradox. We need to adopt change, but we also need to have rules and norms and ways of doing things, established ways of doing things. So we need to really study institutions and how we can do away with the harmful ones and maybe retain the good ones. So why are they stubborn? They are stubborn because they are held in place by three pillars. So the first pillar is the regulatory pillar. This comprises of your laws and your rules, things that have actual serious consequences. If you break them, you are put in jail, you are fined, you are deregistered. So that's regulation. Usually laws follow under this sort of regulation. So if you do this, you get punished by the law. Then there's the normative pillar, which basically enforces a normal way of doing things. Things that there are no laws to enforce norms, really. You won't get arrested if you break a norm, but you'll be shamed. There is some punishment, some societal punishment. You'll be shamed, you'll be banished from a society or something, but you will not get fined or arrested. But yeah, there will be some consequence. So that's the normative pillar. If you do something that goes against the norm in healthcare, there are ways of shaming you. Then there's the cultural cognitive pillar, which totally sort of enforces cultures and ways of seeing. So these are not norms as such, and they're not rules, but these are just the templates we have in our heads about how do we dispense, how do we fill prescriptions. These are established ways of doing things that we cannot comprehend any other way of doing something once we've established a cultural or cognitive framework of doing something. So in layman's terms, a regulatory pillar is what must be done or else. A normative pillar is what should be done, what's right, what's moral, what's good. And then the cultural cognitive pillar means what is generally done, so how do we do things in general? Right, next slide, please.
Okay, thanks.
I'm sorry, I'm in the car with other people who are talking. I hope that's not disturbing you. Right, so how institutions hinder adoption of digital technologies. So when we're talking about digital technologies, we're interested in institutional barriers for the reason that institutions are notorious for hindering adoption of digital technologies. So this slide contains examples. It's a busy slide, but it contains examples. And most of them are actually from high-income countries, just in case you were tempted to think that adoption problems are only in low-income countries or middle-income countries. Even high-income countries, wealthy health systems face problems introducing digital technologies for the same reasons. There are institutions that are barring the smooth adoption of those technologies. So, for example, when electronic prescribing was introduced in high-income countries, there were people who were very reluctant to dispense electronic prescriptions because they thought this was illegal. And for a while, it was illegal. But even when it became legal, people still felt that there were legal sanctions to dispensing electronic prescriptions, particularly for narcotics. This was particularly prevalent in the US. The Medical Information Service, which I founded in Zimbabwe, it took years for it to be allowed, because what it does is it just tells patients which pharmacy has in stock the medicine that they're looking for. So they don't have to walk from pharmacy to pharmacy looking. So this was particularly crucial during the pandemic, where we wanted to limit the mobility of people. But that service was challenged on legal grounds, because there was a thinking that to operate this service, I would need to be advertising medicines, and advertising medicines in Zimbabwe, and I suspect in many of your contexts, is not legal. Pharmacists cannot advertise medicines, and the regulators were of the assumption that for me to run the Medical Information Service, I would essentially be advertising medicine. So it was challenged by the belief that what I wanted to do was advertising. It was challenged by the laws that said advertising was illegal. So that is a whole different presentation, and I don't want to get into it. I just want to give a high-level overview of how institutions can hinder technological adoptions. And there were times where, in some contexts, electronic prescribing was actually legal, but pharmacists just felt that, no, we are used to paper copies. We want to dispense prescriptions that are handwritten. That is what we're used to. So you see that the norm that they are used to, they are holding on to that tradition. And also the idea that contacting a prescriber following an electronic prescription was not very easy to do. They were used to the traditional ways of communicating with prescribers, making telephone calls, and they wanted to hold on to what they've been used to. So these are some of the challenges, the institutional challenges, that when you try to introduce a new way of doing things, when you want to go paperless, when you want to introduce a new technology. Next slide, please. Right. So before we talk about how to address these inhibiting institutions, we need to be able to identify them, because they're such a part of us. If we are not out there specifically and deliberately looking for institutions, we might not actually see. We might think that the challenge is just, people are resistant to change, there's no money to implement digital technologies. Most of the challenges that are associated with the adoption of digital technologies have nothing to do with money or people's resistance to change. They've actually more to do with institutions, people's deeply held beliefs and traditions and ways of doing things. So how do you identify, how do you know that I'm dealing with an institution here? So for example, you listen to what your opponents are saying, and you look at what they're doing to oppose the technology that you're trying to introduce. So if you hear words like, it's not legal, what you're trying to do is not legal, you're dealing with a regulative pillar, you're dealing with a law, which is basically an institution, or it's not allowed. So, and if you hear words like, it's not proper, it might be legal, but it's just not proper, or it's not normal, that's abnormal, it's not illegal, but it's not ethical. No, it's not ethical to do that. It's not professional, it's not right. You're dealing with the normative pillar, the thing that makes pharmacists, that deeply held specialness, that we're a special breed of health professionals, we're ethical, this is our professional way of doing things. It's not illegal, but no, our professional code says we shouldn't do A, B, C, D. You're dealing with the normative pillar. And when someone says that's not how we do things here, or it's never been done here, or this is what we've always been doing, this is how we know how to do it, you're dealing with the cognitive pillar. People have not learned an alternative way of doing some things. And in terms of actions, when you get arrested for trying to do something or threatened with arrest, then you're dealing with the regulatory pillar of institutions. You're dealing with an institution right there. If you're threatened with deregistration or delicensure, again, yes, you're stepping on an institution that is being held in place by the regulatory pillar. If you're shamed for trying to introduce something new, if you're shunned from society meetings, if you start to lose your professional colleagues because of what you're trying to do, you're being shamed, you're being punished for tinkering with an institution that is held in place by a normative pillar. And if you try to explain how the thing works and you are met with confusion, people are really not understanding how the thing that you're trying to introduce works, you might be either explaining it properly, or if you're explaining it properly, you are dealing with the cognitive pillar. People cannot
grasp a new framework of doing things because they have a template already of doing things and they are really facing a hard time understanding what you're trying to introduce. Then you know you're dealing with an institution that is underpinned by a cognitive cultural pillar. Next slide, please. So having identified that you're dealing with an institution, how then do you go around combating it? It's important we know how to combat these institutions because here's the thing, if your problem is resources, if someone says, no, we want to implement this, but we have no money, that can easily be solved. You can fundraise, you can get money. But when you're dealing with institutions, it's a special breed of problem. So you need special tools, you need special skills in order to address institutional barriers once you've identified that you're dealing with institutional barriers. So if your institutional barrier is related to a law, right, or an interpretation of an existing law, you might go to Parliament and seek the amendment of that law or the repudiation of that law or the creation of a law that enables the adoption of the technology that you're trying to do. Or if the problem is just simply the misinterpretation of the law, like that was the case with the Medical Information Service. What I wanted to do was not at all illegal, but the interpretation of regulators of the law made them to conclude that this thing was illegal. So in that case, you have an easier time because you can then simply go to court, which is what I did. We went to the High Court and to the Supreme Court, and we got a judge to interpret the law for us and then pass a verdict that no, this service was not illegal according to the current legal framework. So these are two things you can do when you're dealing with a regulative, an institution that is underpinned by a regulative pillar or a regulatory pillar. If you are dealing with the normative pillar, that might be a bit more challenge because you can't then go and force people using the law to see things your way. That is something you can do with the regulative pillar, but you can't do with the normative pillar because this is people's beliefs. You can't force people to believe what they don't want to believe. However, you could find allies who could help with help with convincing people to abandon old ways of doing things and justifying new ones. You could try to sort of portray the new thing you're trying to introduce as beneficial, highlight the benefits, maybe get some early adopters to demonstrate that this is the new norm. COVID brought all sorts of new normal things. So that helped with so many norms. The COVID was obviously a hideous pandemic. We lost lives and lost colleagues and loved ones. But the one thing that it did was it shifted norms. So that really fast-tracked the adoption of many technologies, as other speakers have already highlighted. And then we can also just start to stop shaming people who are trying to do new things. The best way to help is to then try to understand what the technology does and share your concerns. You might even then find that you can improve it. This is what happened with me with the Medical Information Service. I got tons of help from people who said, okay, you know what, these are our concerns with your service. And then by saying something like that, by not shaming me, by saying, okay, these are our concerns, how can we help you do better? It sort of helps to improve the innovation in the first place. And also it encourages others to come up with their own additional innovations when they see that introducers of innovations are not victimized or shamed out of the profession. If you are dealing with an institution that is underpinned by a cultural cognitive pillar, the simple thing you can do is to just start doing the thing that you want to do. Start implementing the technology you want to implement. Of course, you can't do this with the regulative pillar. If you just go ahead and bulldoze and start implementing something that is contrary to the legal framework, you will be arrested. But if you are sure that you are dealing with a cultural cognitive pillar, you're not breaking any laws, just go ahead and implement the new. When people see the new, then they start to see, oh, this can be done. They start to form a new framework, a new template, a new cognitive template in their heads. They start to understand exactly what's involved in using the new system. So these are some of the ways you could overcome institutional barriers. Next slide, please. Oh, is there a next slide? I'm not sure anymore. Oh yeah, this is the last slide. These are just the references that I cited in there. So I tried to be very brief. The last time I gave a similar presentation, it took nearly an hour. So I'm sorry I had to rush through it and take out a lot of pictures and omit a lot of storytelling. But I'll be happy to field questions either in the chat or even via email. If you can get my email from the moderator or during the question and answer segment. Thank you.
Thank you so very much, Dr. Murray. We really appreciate the succinctness in this message, because I think for all of us across the continent, we have one barrier, institutionalized, whether legal, whether normative, whether cognitive. And so the steps that you have clearly highlighted will come in very useful going forward. Thank you very much for the time and energy you put into this presentation. Okay, so our last presentation, the speaker 4, is Dr. Irene Olweni, and she's talking about accessibility of pharmacists to support emergency preparedness and primary health care in Kenya. A pause before I go on. Please, at the end of the fourth presentation, as many of us that can, I will request that you kindly put on your video so that we could take some group shots of those of us that will still be in the call at that time. So after this presentation, we will take some group shots. So if you're not well dressed, please, I'm giving you notice now. So please dress up so that you can put on your videos so that you can join us in taking the pictures. So Dr. Irene Olweni obtained her Bachelor of Pharmacy in 2010 from the University of Nairobi. She later followed through in the same university and did her Master's in Business Admin with a major in Strategic Management. She is currently the chairperson for the Pharmaceutical Society of Kenya, Nyanza branch. In this branch, she has successfully organized a scientific symposium which accommodated pharmacists from the larger Western Kenya region. She is also a lecturer at the Kenya Medical Training College in Kisumu in the Department of Pharmacy. Please join me as I welcome Dr. Olweni for her presentation. Dr. Olweni, over to you.
Thank you so much, Dr. Jordan. I don't know if my video is visible.
Yes, ma'am, we can see it.
All right. So first and foremost, I'd want to say thank you for the opportunity. As we look at accessibility of pharmacists in primary healthcare, we'd want to first of all understand what primary healthcare is all about. And it basically just means this is essential healthcare. This is essential healthcare that is based on a practical, scientifically sound, and socially acceptable methods and technologies. And this is made universally acceptable and accessible to individuals and families throughout the community. And of course, we know that cost is an important function, and therefore it should be at an affordable cost to the community and therefore to the country. And with all this, it is in the spirit of self-reliance and self-determination. So with that, because that is one of the mandates of the President of Kenya, and for him, he looks at health in terms of strengthening the primary health care. And it's one of the things that he's really, really focused on. So the Department of Health generally
Dr. Olweni.
focused. Yes?
Dr. Olweni, please, could you move closer to your microphone? Your voice is not coming out too clear.
Sorry, ma.
Thank
Is that
you.
any better?
Thank you. Yes, it's much better. Thank you.
Okay, if that is it, then allow me just to close my video for now.
All right, that's fine. That's fine.
Thank you. Thank you so much, ma'am. So when we discuss primary healthcare, we definitely know that primary healthcare cannot be successful without pharmacists in it. And therefore, the two main pharmacists who play a big role in primary healthcare will be clinical pharmacists and community pharmacists. And of course, we all know that they have distinct roles and responsibilities, and each of these types, and each of these pharmacists is able to contribute significantly to the healthcare system. So first and foremost, we look at the entire network, that is the primary healthcare network. And this is basically the administrative region that comprises of the hub and the spokes. The hub is the primary referrals facility, which is usually a level 4 facility, while the spokes are usually the level 2 and the community health units. So these hubs and spokes are able to deliver access to primary care network for patients as they coordinate, as well as coordinate with other hospitals to improve the overall efficiency of the network. Next slide, please. Dr. Joda, I think you're stuck on that slide.
I've moved now.
You have moved. Okay.
I don't know why there's some kind of delay between the movements. Has it
No.
moved now for you?
For me, not yet, but I'll just move on because I still have my presentation in another device. Yes, now it has moved. So we'll start by looking at clinical pharmacists. And we all know that clinical pharmacy is the branch of pharmacy in which clinical pharmacists provide direct patient care. So this helps promote health, wellness, and prevent disease. So who exactly are clinical pharmacists? These are healthcare providers that are responsible and accountable for medication therapy and patient outcomes. So if we move along, we know the roles of clinical pharmacists. We are pharmacists ourselves. So for those of us who are in the clinical space, we are able to understand what we do. So we can move to the next slide. So when you look at the roles of the clinical pharmacist, the first role is medication management and optimization. And this is something that we all do, especially medication therapy management, where we assess patient medication regimens and ensure that their prescribed medications are safe, effective, and appropriate for the patient's condition. Still under management of medication, we look at medication reconciliation, which is a very important aspect. And this is reconciliation of medication lists during transitions of care to minimize risk of medication errors and adverse events, which we know are a big, big menace and lead to even longer patient stay in the hospital. The second role of the clinical pharmacist is on patient education and counseling. So clinical pharmacists are able to educate patients on proper medication use, potential side effects, and of course, the importance of adherence. So they provide lifestyle counseling and support for managing chronic conditions, and we all know what they are, in particular diabetes, hypertension, asthma, and all the chronic diseases that we have available. Clinical pharmacists are also able to ensure interprofessional collaborations where they work closely with physicians, with nurses, and other healthcare providers to optimize patient care. In the same way, they also help to attend conferences and they participate in care planning, medication-related discussions. Pharmacists are also able to do prescribing and medication adjustments, which I am impressed by my other panelists who mentioned that sometimes people feel like pharmacists should not go beyond what they are supposed to do, and they should only be able to handle a paper prescription. So for a long time, people did not know that pharmacists are able to actually go into prescribing. And for right now in Kenya, pharmacists are being allowed, there are even insurance firms that are allowing pharmacists to look at basic or minor ailments, go through consultation, prescribe, and even dispense the medications. So for prescribing and medication adjustments, pharmacists are able to adjust prescriptions and even write prescriptions after assessment of especially the minor ailments. And finally, pharmacists are also able to conduct clinical assessments. And here they perform clinical assessments such as monitoring of vital signs, conduct basic laboratory tests, and evaluate medication therapy and patient progress. So when we look at the other side of primary healthcare, we have community pharmacists. So these are what we call chemists. They are experts on how to use medicine. They're able to dispense medication and prescriptions, sell over-the-counter medicines, and give advice and treatment for everyday health outcomes. If you can move, Dr. So when you look at the roles of the community pharmacists, so this is just an overview. So number one, they're able to go through medication dispensing and supply chain management. Here, there's basic typical dispensing of the prescribed medications to patients, ensuring that the medicines are accurate and safe. Pharmacists are also able to offer counseling on medication use, potential side effects, and storage requirements where necessary. Pharmacists are also able to ensure that supply chain logistics are managed adequately. Another role will be medication adherence support, where pharmacists are able to promote medication adherence by educating patients about the importance of taking their medications as is prescribed. Then, of course, we have over-the-counter medications and healthcare products. Here we have community pharmacists advising patients on the appropriate use of over-the-counter medications and even other health products that a patient may be able to require, including offering guidance on the self-care and even on the minor ailments. And pharmacists are also able to conduct mentorship and supervision both of the younger pharmacists. And I'm glad to hear that Dr. Joda was a senior lecturer and has trained one of the panelists who was before us, which was a good thing. And pharmacists, especially in the community, are also able to conduct extemporaneous preparations of any product that is required. If we can move on. So when you look at all this, we can move to the next slide. So when you look at all this, what are the opportunities in Kenya? So in Kenya, when you look at the opportunities, especially in the primary care networks, we have the expanded scope of practice. And here, a pharmacist is able to prescribe a wide range of medication and provide a more extensive clinical service, unlike what we used to know in the previous years. This includes immunization services. These are part of expanded scope of practice. For a long time, people never thought that pharmacists will be able to prescribe and or issue immunizations. But right now, we are aware that pharmacists are able to conduct vaccinations for common preventable diseases and even the travel-related vaccines. Then we have telehealth. Telehealth is something that we cannot exhaustively talk about. During COVID-19 in Kenya, especially around Kisumu, there was a lot of telehealth technologies that came up. We had several hubs that were conducting a lot of telehealth. So the people in the community will be able to call in, give their symptoms, and be directed on what to do. So that was actually something that was strengthened a lot in Kenya. And we also look at medication therapy management services for the pharmacists. And here we see that this helps to optimize medication use and improve patient outcomes. This is a new line of pharmacy practice, and it is slowly becoming a very important aspect. When you look at the community pharmacists, they are not left out, including the opportunities that we mentioned above. They also have integrated care provisions where medicines optimizing services are integrated into the local care pathways, and there is coordination to avoid duplication of products, duplication of services, and this ensures seamless care. Other opportunities is that there's structured medication reviews. So delivery of structured medication reviews, this is done especially in the primary care networks, and it helps to assist the patient understand their medication, especially those who are on chronic illness. And with this, it also helps to identify inappropriate polypharmacy and patients that need structured medication review. And then we also have accreditation, where community pharmacists are now being accredited as healthy living pharmacists, where, as I mentioned before, these community pharmacies are able to provide preventive and public health services, including even being accredited by insurance companies for management and for consultation of minor illnesses. So we look at more opportunities, and for the clinical pharmacists, we can move on. So for the clinical pharmacists, the opportunities are still not exhausted, and you can see that there's a patient-centric multidisciplinary role. And here, the clinical pharmacist is able to collaborate with the multidisciplinary team for patient assessment and treatment, and they utilize their expert knowledge of medicine to ensure patient care. The pharmacist is also able to conduct diverse consultation. And of course, here we are looking at optimized telehealth. Nowadays, you're able to reach your pharmacist either by a phone call. We have portals, we have digital technologies that you're able to order for your drugs, that you're able to call your pharmacist, that you're able to discuss with your pharmacist. And that is actually helping a lot in terms of the various settings where we even have care homes. So a pharmacist does not necessarily have to be physically present, but they can be able to give guidance in such settings. So a pharmacist is also able to optimize chronic disease management. And here they work closely, of course, with the team of experts to ensure that maximum benefit of medication is achieved by the patient. And then there's also shared decision-making in consultations. And finally, for the pharmacist, there is a proactive medication management, where the focus especially will be on the elderly, the care home residents, and those with multiple conditions and learning disabilities. So you'd have to undertake structured medication reviews for the complex polypharmacy cases. You can move on. So what are the constraints in all this? Of course, we know nothing comes in easy. We have regulatory barriers. And as we said, is that most people do not know what clinical pharmacists do. Most people don't know where pharmacists are, especially in the primary care network. And therefore, pharmacists, with all this information, people are able to be informed that pharmacists are able to utilize their skills and even be able to prescribe. Then there is resource constraints, where there is shortage of clinical and community pharmacists in areas, especially in the spokes. So you find most pharmacies are available in the major cities. So in the small areas, in the villages, in the rural homes, they are not available to issue comprehensive pharmaceutical care. And finally, there is the interprofessional collaboration. There has been a lot of challenge, even for those who are in practice. You'll realize that other cadres don't appreciate what pharmacists do, and therefore, with the hierarchies and communication barriers, that brings in a lot of challenges where people feel like pharmacist is a smaller or a lesser healthcare provider. But with time, this is slowly being changed. So what is the future of pharmacy in Kenya, especially in the primary care networks? Is that the future holds significant promise, and this especially with the expanded scope of practice, as I've said, and with enhanced collaboration and harnessed technologies, pharmacists can be able to play a substantial role in improving healthcare delivery. And then we also have initiatives that focus on improving medication management, patient education, and medication adherence. These are likely to lead to better patient outcomes and more efficient healthcare systems. And finally, investments in a pharmacist education and training is also very essential to ensure that pharmacists are well prepared to meet the evolving healthcare needs of Kenya's population, and I'm sure this also works with the African population. So with that, thank you so much, and I'll take questions as I am guided. Thank you.
Thank you so very much, Dr. Owini. Very, very clear and concise presentation and a lot of take-homes. There's that discussion. I think it's all over the continent about what the pharmacist does. Who is the clinical pharmacist? Why do we need community pharmacists? So I believe those discussions are going on all over the continent, and I believe that this presentation has helped to put some clear definitions and rules forward, which we can all take forward to use in our various spaces. So thank you very much. I've not seen any questions in the chat box, so I'm going to assume that everything that has been shared has been very, very clear. Unfortunately, we have used up all of our time, and so I'm not sure we can take any virtual, any open discussions. But if there is somebody that has something particularly that they would like to share, and the person can quickly put up their hand, we may be able to accommodate you if there's something, and please let it be something unique that you want to share. Otherwise, please go ahead. Dorothy, your hand has been up on and off throughout the presentation, so I'm going to allow you. But quickly, please, no inaugural lectures, ma'am. I hope she can unmute herself. Allowed to talk. Did you see my call to allow you to talk? I'm not sure she can unmute herself. Also, doesn't look like she can unmute herself. So if the question is around, will we get the slides? As usual, all of them, FIP's presentations are online, and you will be able to access it from the FIP website, the events website of FIP. Dorothy, are you able to unmute yourself? I don't think so. Okay, so let's just go on. As I said, if you go to, from a few days after today, or later today, if you go to events.fip.org, you'll be able to see the recording for this event, as well as all past FIP digital events on the website. Unfortunately, you will not be able to download the presentation, if we have the permission of each of the authors, we may be able to share the slides around. Otherwise, you would need to use the recording to listen and listen and listen, because quite a number of things have been shared here today. So just to give each speaker, I thought I would give each speaker 3 minutes, but now I'm giving each speaker just 1 minute to wrap up, so that we can close this session. And I'll start from the back. I'll start from Dr. Oweni. Just a minute to just wrap up the session. If you think you don't need it, no problem. Yeah, please go ahead.
Thank you so much. Thank you. For us as pharmacists, it is important that we always take advantage of every crisis, grow ourselves, and always showcase what pharmacists do and make ourselves relevant. Thank you.
Thank you so much. Thanks. Those are great words to go by. Dr. Murray, please.
Yes, thank you. Just as a final word to say, again, pharmacists, there's so much scope as pharmacists, with so much scope for making positive changes in health systems, in our health systems. And most of the problems we face have nothing to do with resources, but obviously I'm biased towards saying institutions are the cause of problems. And I hope you go away and read around and reflect on all the challenges you've faced in the past, and see if you can identify institutions from there and see if you can challenge those. Thank you.
Thank you. Thank you so very much. Sam Okwanobi.
Ma'am, I guess my wrap up would just be this: technology is your friend. Look for ways to use technology to improve whatever you are doing. It's an enabler, and you may not necessarily find the immediate technology in your industry. You can find it in another industry, and can then bring it into your industry and see how you can use it for scale and all the rest. And I wish you luck on your journey with technology.
Thank you. Thank you. Samuel, please. Akufo.
Yes.
Sorry, just 1 minute. Just 1 minute, sir. Irene and Dudze, can you put on your videos, please, so that I can at least take the panelists? Please put on your videos. Shino, put on your video back. Yeah, go ahead. Go ahead, please.
Okay, so I'd say that these have been very great presentations. I appreciate the time. And I'd like to encourage everyone that technology is here to stay. It's not going anywhere. And so let's get into it. Sometimes we get bogged up in the fancy technology, but the truth of the matter is that the technology itself, yes, may look fancy, but there are people behind it, right? And so we need to focus on the health, how we integrate the technology within the healthcare system itself. And that's where the work is. And that's where pharmacists come in. So let's be open-minded about that. Thank you.
Thank you very much. I'm not sure I did a good job of taking the pictures. Shino, please, can you help in taking a screenshot? I'm not sure I did a good job. And while you are doing that, I would just like to appreciate everybody for taking time out to join us on this second APF webinar, and to tell you that there are more to come after now. And of course, we all know that in September, we are going to South Africa for the FIP conference next year. So please start packing your bags from now for that time. So 1st to 4th September 2024, we'll be in Cape Town, South Africa for the 82nd FIP World Congress of Pharmacy and Pharmaceutical Services, and we're all welcome to join. Please reach out to as many of your colleagues, because it's an African, we're making it an African FIP. So we want everyone to be there, everyone to, okay, sorry, I should have stopped sharing. Everyone to be there, everybody to come and represent your country as we uplift FIP with the African flavor, you know. So, and thanking each of you, from Samuel Akufo, from Shino Panobi, Dr. Dudze Morey, Dr. Irene Oweni, for the great input, great impact, and to ask if it's okay to share your slides with participants so that we can do that, if that's fine by you. And then the recording will also be available. Thank you, thank you, thank you. We have our president, the APF president, online. She just sent me a message. And I would like to give her 1 second, 1 minute, just to say hi to the continent. Farm Shiva, just 1 minute, please, as we round off this webinar. I had planned to do that earlier, I forgot. So she sent me a message just on time. Are you there? Farm Chai, oh, she won't be able to unlock, sorry. Okay then, so we're happy to be here. We are looking forward to FIP in 2024. And everybody, thank you for being here. At some point, we were about 85 participants on the platform, and it's really great to have so many.
She can unmute and speak if you still have time.
Okay.
She can unmute and speak.
Okay then. Jocelyn, are you
Jocelyn,
there?
yeah. You're able to unmute.
Yeah. Oh, thank you. Thank you, everyone. Thank you for the beautiful presentations, putting Africa on the map. Dudzai, Adeshina, Samuel, and Dr. Rinola. Thank you, everyone. It's been a wonderful presentation, and it actually applies to us as pharmacists as we move forward and taking technology into our armpits. Thank you, everyone. God bless.
Thank you. And Dr. Irene, thank you very much. Everybody, happy holidays ahead. See you next year. Bye-bye. Thank you so very much. Thank you. Platform that I need to see.